Welcome to my podcast, The Laura Dowling Experience. Many of you will know me from my Instagram page @FabulousPharmacist, where I shine a light on topics that people normally shy away from. Today I spoke to Consultant Obstetrician Gynaecologist Dr. Gerry Agnew. He specialises in urogynecology. We had an in-depth discussion about prolapse, urinary incontinence, sexual dysfunction, and vaginoplasty. We answered all of your questions. To support the Laura Dowling Experience, please take a look at our sponsors in the podcast notes below. Enjoy the show. So I'm here today with Dr. Gerry Agnew. He is a consultant obstetrician gynaecologist, and we are here today to talk about urogynecology. And I put out a question box on my Instagram, and Gerry, I have never had so many questions in about it. I'm sure you know it's a real hot topic at the minute. Women are being made much more aware about it and much more aware of how we can help ourselves if we do suffer from urinary incontinence, prolapse, vaginal issues. So where do we begin? Prolapse, I suppose, really. Isn't that the...
Yeah, absolutely. I mean, I'm not surprised that you're inundated because all the patients say that, you know, when they come to see you, that their friends are all waiting to hear how they got on, and that they, you know, when they're finished treatment, they're usually saying, I have 6 friends now. They're all going to be coming. They're all asking about it at the golf club. And so it doesn't surprise me that there's such a huge interest in it. I keep hearing women saying, I wish women would talk about it more. I wish it was more talked about. But I seem to do nothing else but talk about it all day long.
So. I see you, and I've done some panel discussions with you as well. And so maybe let's go back to the start. What is prolapse?
Okay.
How can someone recognise that they have it? And where do we go from there then?
Okay.
And how does it happen?
So there's a bowl of support in our pelvises. And this support is made of muscle and elastic tissue, blood vessels and nerves. And this bowl of support holds everything in the correct position. Now, the problem for women is that when you have a child, particularly a vaginal birth, you're going to put that elastic tissue of support, that bowl of support, under tremendous stretch and pressure. And often it just never comes back as good as it was after delivery. Some women have symptoms immediately after the birth of their child. I had a call today from someone who just delivered a week ago, and she knows that she has a prolapse and she wants to be seen. You see a group of women straight after having their babies, but actually the larger group are women who the damage was done at that time, but they were able to compensate. They got away with it until they hit the menopause. Mm-hmm. And when they get into their 50s, late 50s, early 60s, the estrogen levels start to go down, and those tissues, those elastic tissues, become a bit thinner and a bit weaker. And often the damage that was done at the time of childbirth starts to show itself at that time. So you might say, well, what are you talking about? So women would say, I feel something coming down. So they'll say, I'm okay in the morning. I get up out of bed. I'm fine in the morning. But by the end of a day, if I'm on my feet all day, I start to feel this dragging sensation, or I feel like there's a tennis ball in my vagina, or a bulge coming down or out. They may have low back pain. And a lot of women will say, when I have a shower at the end of a long day, I can feel something there coming down to the entrance or beyond of the vagina.
Does it come out sometimes as well?
Yes, it can come very far out. Now, thankfully...
Is that dangerous? Like, I mean, does that cause infection then? If it's,
no, it doesn't really cause infection.
And what is it that's hanging out?
Well, exactly. So there's 3 things that can come down. There's a common misperception that, my womb is falling down. And that's why I'm here. The womb is actually, or the uterus, is the least common thing to come down. The bladder and the bowel are much more common. So the bladder and the bowel are neighbours of the vagina. The bladder and the front wall of the vagina, and the bowel, the back passage, is on the back wall of the vagina. And when the vaginal walls are weak and not supported, they bulge into the vagina and out through the entrance. So when you see a bulge, it's vaginal skin, but underneath that vaginal skin is the bladder or the bowel, and then they can't work properly because they're not in the right place.
Okay. So when women are saying that they feel that they can't empty their bladder properly, like I've had lots of questions in, they say they go for a pee, but they don't feel that they're emptying it properly. That's the bladder coming down?
Well, if you think of the vagina, say like this room.
Yes.
So the bladder lives just above the ceiling tiles, okay? And when you have prolapse, it's the actual ceiling tiles that are damaged. So the bladder, which is the water tank just above the ceiling tiles, that's now hanging down into this room. And so when a woman wants to pass urine, The urine should come down from the kidneys into the bladder, and when she wants to go, she should be able to empty straight out. But when that bladder or tank or whatever you want to call it is hanging down into the room here, she's trying to get the urine up and out.
Okay.
And that's why she can't empty properly. And that causes other problems, because if you're not emptying, the bladder doesn't like old urine lying around. It wants fresh urine and it wants to empty. So if you leave some of the urine behind all the time, just like any puddle or collection of water, it'll become stagnant, and that will irritate the lining of the bladder, this old urine that's there, and that'll cause urgency, frequency of wanting to go to the loo, always feeling that you're not fully empty, and it can make you prone to cystitis and urine infections, because bugs love old urine.
So if a woman is experiencing, and I would see it in the pharmacy, a lot of UTIs, and that can be a symptom of actual prolapse.
Absolutely.
Okay.
The first thing I want to see is there a prolapse there?
Okay.
And actually, I'm nearly hoping that there is, because a prolapse, if you correct it, then it might sort the problem out.
And
but a lot of women get urine infections who don't have a prolapse.
Yeah. And how do you correct it? What is involved in that? Because I know there was mesh surgeries years ago, and...
Yeah, I can explain that. The way we fix it, going back to use the room analogy, so if the ceiling is damaged and it's allowing the bladder to hang down here into the room, what you actually do, you're not sewing or repairing the bladder. You push the bladder back up to where it's supposed to be, and it's the ceiling of the vagina that you're repairing. So that's what you stitch together, that the elastic support that holds the bladder in place, and that puts it back in the right place. Now, if a woman has naturally very weak tissue there, no matter how beautifully you sew it together, if you're sewing cellophane to cellophane, it's still cellophane.
Okay.
And she's filling her bladder several times a day, and that pressure over time can cause things to sag down again. And then she can have a 20 to 40% chance that even if you fix it beautifully, in a few years' time, it can come down again. And that's where mesh came into the picture, because mesh was being used for many, many years for hernia repairs. And that's a similar problem. It's a weakness of the elastic support. So you correct the defect and you put a layer of mesh over it, and that gives the extra support so that it doesn't recur. So people thought, wouldn't it be great if we could fix a woman's prolapse and it stays fixed forever, that she never has to get it done again, and she stays as good as the day we did it. So people started to put layers of mesh in after they've repaired the ceiling, reinforce it with a layer of mesh. It seemed like a good idea at the time, but very quickly, within the first couple of years of it being used, we started to hear reports of pelvic pain with intercourse. You could see mesh eroding through into the vagina, and very quickly we saw that this was not the solution that we were hoping it was going to be. So if you didn't have those complications, yes, you got a good support that stayed supported. But unlike hernia repairs, there was a higher degree of complications with it. Okay. So the world generally has moved away back to where we were in terms of just doing natural tissue repairs and living with the risk of recurrence.
Okay. And then how common is it? Because I know we're not supposed to use the word that it's normal for it to happen, as in a prolapse isn't necessarily normal, or how normal is a prolapse, but how common are prolapses in women?
It's extremely common. So 1 woman in 4 will have surgery for prolapse or incontinence at least once in her lifetime. And
it's quite a product default, isn't it, the female anatomy, in terms of, we're supposed to give birth, and then giving birth naturally actually causes this, and then you'd have women saying, I'm going to get a C-section because I don't want this to happen. So what are your thoughts on that? Yeah,
it's funny you should say that. I mean, we don't encourage, cesarean sections electively on a first birth. We still very much want things to happen naturally, and for women to have birth the way it was intended to. But you do get, I certainly have seen in the last few years, more women coming forward. Women who maybe have a family history where their mother has been down this road with these problems, or their sister has been down the road with pelvic floor problems, or they are physiotherapists themselves, or they work in theatre.
or they're obstetricians
themselves. There was a study done in the UK a number of years ago asking female registrars in obstetrics and gynaecology what would they personally prefer, and a majority of them preferred an elective cesarean section.
Yeah.
But there's a lot of factors. It depends on your family factors. It depends on how many children you want to have. You know, I think maybe down the line, not in my career lifetime, but we'll eventually, I would think, have genetic testing, which will identify women who are at greater risk than others, where it runs in their family and they have a predisposition to develop pelvic floor problems. And maybe for those women, an elective cesarean section might be a good option.
And then is there anything that you can do to prevent it, you know, either when you're pregnant or not pregnant?
Well, physiotherapy, pelvic floor exercises, things that will improve your tone of your pelvic floor is definitely going to help. But in terms of childbirth is without doubt the biggest risk factor. So having a baby, a vaginal birth is a greater risk than a cesarean section. If you have a vaginal birth and you end up having a vacuum delivery or a forceps delivery, that's a greater risk than a normal vaginal delivery.
Okay.
Which makes sense because they're a difficult birth by definition. The fact that an instrument was used was because it wasn't delivering. So things were being stretched more.
Okay.
So the problem is that by the time that happens, you're already committed.
Yeah, of course.
You know.
And in Ireland, though, we're not necessarily known for great follow-up post-delivery, are we? You know, in France, there's physiotherapy for, I think, up to 6 months after giving birth. In Ireland, there really isn't that. It isn't, I don't know whether it's just not seen as important, whether the funding isn't there. But certainly, like, I remember, like, I had 3 babies. They were big, like 10-pounders, and you're just literally packed off, you know, once everyone's babies, you know, put on the 10% weight or not lost more than 10% weight if you're feeding it yourself, and you're sent home and you're told to do them, but you're not really told how. You're just kind of left. Like, what are your thoughts on that, or is there a progression coming down the line, do you think?
Well, we're definitely getting better. I mean, I work in the National Maternity Hospital and I work in St. Michael's Hospital in Dún Laoghaire, and in both places we've recently hired 2 new women's health physiotherapists in both places. But it's because we're absolutely inundated with the work of the women who already have the problem. Yeah. So, I mean, we could have an endless amount of physiotherapists we could use in terms of what you're talking about in women who don't yet have the problem, in terms of preventive care, getting women doing their pelvic floor exercise and learning how to mind their pelvic floors before and after babies. But at the moment, we're totally snowed under with the women who already are symptomatic.
Yeah.
You know.
And I've had some questions in from women who haven't had babies and they have this issue or they have leaking. So it happens to women even if they haven't had children, isn't that right?
Yes, that's true. Like I said, childbirth is the biggest risk factor, but there are other risk factors if you just, it does run in families. So the most common thing a woman will say when I make a diagnosis and I say, oh, you have a prolapse, the most common thing they say is, oh, my mother's had this, my sisters have all had this. So a lot of times if it runs in your family, even if you haven't had a baby, you can have these symptoms. Not so much prolapse, but you will see urinary incontinence. So stress incontinence, even though they haven't had a child. And stress incontinence is similar to the prolapse, but it's just a weakness. Instead of being the weakness under the bladder, it's the weakness under the tube that you pee from, the urethra. So if the support under the urethra is a bit loose, then that tube is not supported, and then when you laugh or cough or sneeze, you'll leak. And I do see it in women who haven't had babies, but they're very much in the minority. Okay,
and the menopause and weight is also a factor, isn't it?
Menopause, as we talked about before, when the estrogen levels start to drop, those supportive tissues become less elastic, they become thinner and weaker, and you become more prone to these problems. And what was the other?
Weight.
And weight.
Yeah.
Putting on weight. It's the same as when a woman is pregnant. So a lot of women will say, I'm leaking since I got pregnant. And that's a combination of the hormone effect, which has a loosening effect during pregnancy, but also the weight of the pregnancy sitting on her bladder. And it's the same if someone who's not pregnant, if you put on weight, that weight is sitting on your pelvic floor, sitting on your bladder. You will leak more if you put on more weight. Okay.
I know the preventative is, or if you want to try to prevent it, is the pelvic floor exercises even prior to pregnancy, but the chances of women even thinking of doing that is quite minimal, I think, unless there's an entire, like, an awareness program devoted to it. What are your thoughts on that?
I've had women refer to me and they come in and they can be quite upset and angry and say, nobody told me that this could happen.
Yeah.
And if I had known that this was the way that I was going to be after having my delivery, I would not have had a normal delivery. I would have asked for a cesarean section.
Yeah.
And, I probably would see it. I don't see that many people who would say that, but I would see a disproportionate number because they're being sent to me because now they have the problem. But I don't think that was something that was being said, or women were voicing that emotion years ago.
I suppose women were just told to be quiet about that kind of thing. We weren't supposed to talk about those issues, or it certainly wasn't something that was talked about or made aware about publicly anyway, was it?
Well,
even amongst your girlfriends.
I ask a lot of women, did your mother have these problems?
Yeah.
Oh, my mother would never have talked about anything like that. Yeah.
Do you get asked at, are you often at parties and women might just openly talk to you about their vaginal issues, Gerry?
Not so much in Ireland, but I was in Australia once, and we were at a sort of a parents' meeting. I did a couple of years working in Australia, and I was at the bar area, and this guy came up and he said, "Oh, you're from Ireland, and what are you doing here?" And I said, "Oh, I'm a doctor. I'm working in the local hospital. I'm here, for a couple of years training." And he said, "Yeah, well, what kind of medicine do you do?" And I was explaining to him about women's prolapse and incontinence. He's like, "Oh, my wife has that problem. Thunder, come here.
Thunder.
I've got a bloke. Come here. You know that problem?" And she said, she came over through the crowd. She said, "I'm going to kill you. I'm going to kill you." And he said, No, I'm sorting you out. It's the bloke, So
this is the guy to know.
This is the bloke. Yeah, he was taking all the credit.
Yeah. Oh, I love it. And it can affect, so lots of questions then about it. It's affecting people's sex lives. It's affecting, they're also talking about when they're leaking, they are peeing when they're having sex, or peeing when they orgasm, and that that's preventing them orgasming the next time type thing. So
yeah, that's something that I always stress a lot with the junior doctors, that when you're taking a history of a patient, always ask about sexual function, because even the younger women, people are embarrassed about it. Nobody wants to be in talking to somebody about leaking during sex, and women will, the vast majority will not volunteer that information unless you ask about it. But they're always very glad when you have asked about it.
Yeah.
So I always stress how important it is to ask about that. So in terms of sexual function, I would ask them, do you leak when you have intercourse? So if they leak with penetration, it's usually stress incontinence. So it's the same sort of leakage that women get with exercise. If they leak with orgasm, which I don't hear as much people talking about, it's in the textbooks. I've heard it once or twice, but that tends to be more associated with overactive bladder, urgency, frequency type of problem, as opposed to the leakage with exercise.
Okay.
So the leakage with exercise, the stress incontinence, that's far more common that I hear about with intercourse. But then the other question that I always ask is, since you had your babies, has sensation changed? Do you feel that since you had your babies that there's been a big drop off in sensation and that it has changed? And the amount of women who say, "Oh, well, I know that's normal, and since I had my babies, I don't feel anything. But I know that's normal when you have babies." That's not normal, and it's very easy to correct. And that is something that really is something that women really do need to talk about more. Because I do hear all the time people saying about stress incontinence, and women need to talk about it more. But from where I'm standing, I think women are talking about it a lot more. There's even ads on television a lot now about pads for women with urinary incontinence.
Yeah.
But I think I know that there are thousands of women in Ireland who have greatly reduced sensation with intercourse because of this overstretching that has happened when they had babies. And likewise,
and it's the overstretching of the pelvic floor as opposed to the vagina. Because I had someone, she messaged me in and said, "I have a vagina like a hippo's yawn."
Yeah, you're right. It's the entrance to the vagina. So the entrance to the vagina has been stretched.
Yeah.
So as I always teach the junior doctors when I'm showing them how to, or the medical students, how to examine somebody, when you are examining a woman, you should not be able to stand at the end of the bed and go, "You've had a baby."
Okay.
You should not be able to tell that someone has had a baby. A vagina at rest should be closed. And if the vagina is open or gaping slightly, that's not normal.
Okay.
And it means that sensation is definitely reduced. And a lot of women will present with the symptom of, when I go to the gym and I'm exercising, air can come out of my vagina sounding like passing wind. And it's
that was
very
a question.
embarrassing.
That was actually a question.
Yeah.
I think the nice term for it is queefing, but like people call it fanny farting. Like it's not terribly nice, but yeah.
I don't
like
personally use that term.
I'm sure you don't, Gerry. I'm sure you don't. I'm sure you're much more sophisticated than that. But that's what women are referring to, so I suppose. So that isn't normal.
No, that's not normal.
Okay.
And that's because the entrance is wider than it should be.
Okay.
And the other thing, which is a part of the same problem, is when a woman has a baby, nearly everybody ends up getting some suturing or stitches done. They either have an episiotomy or they have a little bit of tearing that they've had themselves. The vast majority, it's very unusual for a woman not to need any stitch at all. So nearly after having a birth, everyone gets a few stitches. And it's very, if you think about it, the baby's just been born. The lighting in the delivery room is often dimmed. It's not that great. You're trying to get extra light in. There's still bleeding going on. Everything is swollen. It's very difficult to get the kind of cosmetic result that you would get if you were in an operating room with everything, all the conditions perfect. So what often happens is either there's too little effort to bring the tissues together enough, or they come together a little bit too much. And that's the other problem. So women will say, well, since I had my babies, intercourse is painful or uncomfortable. There's a tightness at the entrance to the vagina. This also is incredibly common, and it's even easier to correct with a small surgical procedure.
Okay.
Which I often can do in the outpatients.
Okay.
And it only takes a few minutes. And women have put up with this for a year. I have no doubt there are thousands of women in Ireland who have that problem. And
I got a few in asking about that pain with an
so
episiotomy.
easy to fix.
And can it affect the sphincter as well? Because I had a couple of questions about that as well.
Yeah.
If it's stitched incorrectly or poorly.
You mean the anal sphincter?
The anal sphincter, yes.
I'm glad you brought that up. This is a real misperception that's out there, because when we're doing antenatal clinics, women will often bring in their birth plan. So there's certain things that they've read about or they've thought about, and they have a set of preferences. And that's fine, and we go through them with them. And, so long as they're not asking for anything that's not in their interest or is dangerous for them, then we try and accommodate what they would like for the experience. But so many women will have on that, I do not want an episiotomy.
Yeah.
And what they don't understand is an episiotomy, it's not done for the baby. It's not done to try and reduce our workload or speed things up. It's done to protect her anal sphincter.
Okay.
When a baby is being born, it looks just like a wetsuit being pulled over the baby's head. And when things are tight like that, it can just in a split second, it splits and she tears. And once that happened, it's too late now. So the tear has gone down, and it can go down because of the shape of the vagina. It's going to go straight down. So the tear goes down, and if it enters her anal sphincter muscle, that could be damaged irreparably for the rest of her life. She may have problems with leaking wind or leaking feces for the rest of her life. So that's called a third-degree tear. So we go to great lengths to try and prevent third-degree tears. When they happen, it's very important that you detect it at the time and fix it at the time, because that's your best chance of getting it to come together well.
Okay.
But an episiotomy is a cut to relieve that tension before that tear happens.
Yeah.
And you make the cut to one side so that if she tears, it tears to the side away from the anal sphincter.
Okay.
So it's done to protect her.
Yeah.
That's what the whole point of an episiotomy.
And perineal massage, I'm sure you'd be massively into promoting that.
Absolutely.
The almond oil.
Absolutely, because that almond oil and that perineal massage helps soften and makes those tissues stretchier, so they're less likely to have that sudden tear.
I did that myself, and I never forget my husband walking in and me doing it. He's like, I don't need to see. I never need to see that site again. But it worked. I didn't tear at all. So
Yeah.
I'm one of the few
fantastic.
that didn't tear, and I had 10 pounders.
Well, that just shows that those things help.
They can help. So we've talked about the prevention of it, and hypertonic pelvic floor.
Yeah.
That's another issue that.
Yeah, that's an issue where, so everyone always assumes that, my pelvic floor is weak and that's why I have these problems. Usually, if a patient comes in and she's talking about, say, pain with intercourse, not just at the entrance, like what we were just talking about a few minutes ago, but intercourse is difficult for me. It's always painful. I don't enjoy it. And when you examine her, usually when you perform a vaginal examination on someone, you insert a finger, and I ask the woman to squeeze on that finger, and then so it's relaxed, and then she squeezes, and you rate the strength of that squeeze. With a woman with hypertonic pelvic floor, you put your finger or digit into the vagina, and she's already squeezed. It's like there's a spasm. So when you put your finger in there, you feel like a horseshoe of muscle, and it's really relaxed. And you ask her to squeeze, and you feel it squeeze, if she can do it well, and it pulls up on your finger. But some women, when you examine them, immediately it's like in spasm. It's already fully contracting. And that's hypertonic pelvic floor in a simple way of putting it. But so what these women need is not pelvic floor exercises. They need a good women's health physiotherapist who will detect that and then give them exercises and treatments and manual digital relaxation and things that the physios can do to help them to learn to relax those muscles.
Okay.
So blindly doing pelvic floor exercises for someone like that will actually make her worse.
So should everyone then consider going to a pelvic floor physio post-delivery just to make sure that they don't have the hypertonic and do the wrong thing as a result?
I would certainly think so. And so many times women have said, I've been doing that for years. I've been doing my exercises. And then the physios will say she was never doing them properly. She didn't know how to do them. So getting the feedback from a good women's health physiotherapist that you are doing it correctly is, and they probably wouldn't need very much. 1 or 2 visits for most women would be all that they would need. But at least they'd know they were doing it properly, and they'd learn how to sort of feed back to themselves that they're doing it right. Otherwise, they're maybe wasting their time.
And what about TENS machines, in the insertion of them into the vagina? How do you rate them?
I don't deal with that too much. A physiotherapist.
A glass of water there if you want, because you're doing most of the talking, Gerry. So.
It's something that's used by the women's health physiotherapists a lot.
Okay.
And I think, again, it's to help women to get feedback on whether they're working the muscles properly or not.
Okay.
And I know my physiotherapy colleagues use them a lot. So,
okay.
They're recommended.
And then the Emsella chair, how do you rate that? Or?
I think the Emsella chair is fantastic. For one thing, in terms of getting women talking about this issue and knowing that there is a way to optimize working their pelvic floor muscles. Anything that gets women to work their pelvic floor muscles and improve the tone of this area has to be welcomed.
Yeah.
And I think this is a fantastic new technology for people who it would fit with their lifestyle. I mean, a lot of women are very busy on a day-to-day basis, and with all the best will in the world, they don't get around to doing their pelvic floor exercises properly by signing up for a series of sessions where she has to go to it, and it's going to work probably an awful lot more effectively than if she was doing them herself.
Yeah.
The one caveat I would say is that she should be assessed first to make sure she doesn't have a hypertonic pelvic floor. Excuse me.
That's okay.
To make sure that her pelvic floor tone is not hypertonic, and that she knows how to do her exercises properly, and that she does have a weak pelvic floor that would benefit from improved tone.
Okay.
Because a lot of times I'll see women who have the problem with incontinence or prolapse, but when I ask them to squeeze their pelvic floor, they're amazingly good at it. So their pelvic floor muscle tone is actually very good. So a huge amount more of exercising that won't necessarily do them any good,
Yeah.
But when I get someone to squeeze and their squeeze is very poor, they're the ones you really want to. There's way more room for improvement for them.
Okay. So it's more about assessment and then going and seeing which route will be best for you.
Exactly.
And then in terms of how long does someone, when is it considered that they should be coming to you? So, how. A lot of people have said to me, is it best to put off surgery until, and manage as long as you can without it? When is it considered time to go to you? How much leaking is considered bad, or?
Any leakage that is interfering with your quality of life is not good. So it's not like the pelvic floor. It's not a one size fits all. So I remember I always use the example. I had 2 ladies in Australia that I saw, and they both were very, very similar, and they had the exact same level of leakage that I could detect. But one of them was the captain of the ladies' tennis club. Tennis was her life. Her whole social life revolved around tennis, and it was causing a massive problem for her because she couldn't play tennis without, and it was the only thing that was making her leak. And then the other lady, who was exactly the same in terms of the problem that she had, the only time she said she ever really leaked was when she went out with the girls once every 6 weeks or so for a girls' night out and had a big laugh. Was laughing. And that was so one of those ladies needed treatment and the other one probably didn't.
Yeah.
You know?
Yeah.
So in terms of what you should do, first of all, to see a specialist takes time. There's a waiting list. Unfortunately, to see a urogynecologist like myself in the public sector, it's probably about 18 months.
Goodness.
Even to see someone privately is probably close to 6 months.
Okay.
So if you feel you have this problem, I think the first port of call should be a women's health physiotherapist. And there would be nothing wrong with, asking them to refer you to a urogynecologist or ask your GP to refer you.
So women's health physios can refer to you?
I accept physio. Okay. I accept referrals from them all the time.
Okay.
Because I know they've been well assessed.
Yeah.
So I will accept referrals from them or from the GPs.
Okay.
But it's considered very poor practice to go straight to pelvic floor surgery without women having had pelvic floor physiotherapy first.
Yeah, well, that would make sense, I suppose.
Yeah, totally.
Can HRT reverse prolapse?
No.
No.
I think the horse has bolted at that stage.
Yeah.
I mean, it's a good idea. It will improve the quality of the tissues, but it's not going to put anything back.
Okay. Someone said that they get relief when they push their poo backwards with the tissue.
Yes, yeah.
When they're going. Is that normal?
It's not normal, but it's very common when you have a prolapse. So we were talking before about the bladder and that the ceiling tiles are damaged, the bladder is hanging down. If you think of the floor of the room and the floor is damaged, and that's now allowing the bowel to push up from below. So your poo should come straight down and wait until you're ready to go and then go out. But if the vaginal wall is weak, the poo is able to bulge up into the vagina. So instead of going straight out, it's going up into the vagina. So they'll feel a bulge there. And then to try and empty, they will say they'll put their legs up on a stool or they'll lie back. And by lying back, it helps the bulge to fall down back into place and straighten the bowel so that they can pass a motion easier. But if that gets a little bit worse, women find they benefit from physically putting a finger in and pushing the bulge down. And what they're doing is pushing that bulge from the vagina back down to where it should be and straightening the bowel that way. It's called splinting. That's
mad. And it's mad the way that would come intuitively to them. They haven't actually been taught to do that. It's just they feel it, so therefore they know they have to do it as well.
Yeah, God, it's funny because the amount of women who will say to me, now, I nearly hate to tell you this, I'm so embarrassed.
I know.
When I have to do a poo.
Yeah.
I put a finger in my vagina and I push a lump down. And I hear this several times a week.
Yeah.
And they think they invented it, But
I love it.
It is just intuitive.
Yeah, of course. Yeah. But it's unreal. But even thinking about those things that women have to go through for normal day to day going to the toilet, like it is terrible, really, isn't it?
It's very debilitating. Yeah. It has a huge impact on people's quality of life and their self-image.
Yeah, like there's a lot of depression and anxiety around even knowing where the toilet is, because they need to know where the toilet is wherever they go as well when it comes to leaking. And can you talk to me a little bit about the difference between leaking and overactive bladder? Because they're terms that are kind of bandied around together, but there is very much a difference, isn't there? Yeah,
there's two main types of incontinence that women get. So there's stress incontinence, which is very much a physical problem. So the tube that you pee from, the support underneath that tube has become weak. And that tube is not supported. So now when you laugh, cough, sneeze, you just leak without any particular urge to go. Overactive bladder is a different thing. So that's when the bladder is irritated and you feel that you want to go all the time. So usually somebody with the stress incontinence, the first type, they go a normal number of times during the day and during the night. While the other ladies will say, no, when I gotta go, I gotta go. I get that urge. I may make it to the loo, but I may have an accident before I get there. I'm going to the loo way more often than I used to, and I'm going 16 times a day. I'm getting up 3 or 4 times at night to go. And that's overactive bladder. Now, a lot of women have what we call mixed incontinence. So they have a bit of both, because both are very common.
Yeah.
So the overactive bladder type can also be caused by a weakness in the pelvic floor where the bladder is bulging down, so they have a bit of a prolapse, so they're not emptying properly, as we said earlier. So they're leaving this old urine behind, which irritates the bladder, makes them go more frequently. But a lot of women with overactive bladder, structurally, everything is in the right place, but for some reason, their bladder muscle, which is called the detrusor muscle, is oversensitive. So we all know what it's like to put your key in the door of the house, and you didn't need to go to the loo a minute ago, but as soon as you put the key in the door of the house, all of a sudden you feel the urge to go, because your brain knows that the toilet is near and it thinks, oh, I'm in the loo now.
Yeah.
So it sends down the message to squeeze the bladder and to relax the exit and to let urine come out. So you get that key in the door feeling. Women with overactive bladder are getting that all the time. So they're in super value with their trolley, and they get that key in the door feeling of urgency. Got to go right now or I'm going to have an accident. They have to abandon their trolley and go run hunting looking for toilets. So in terms of career, in terms of day-to-day life, it's very debilitating.
Yeah, no, it is. And then what about Botox for that type of issue?
Yeah, Botox is fantastic. It was a huge breakthrough when it first came out. We started using it probably about 12, 15 years ago.
Great, you can use it everywhere, your face, your down belows.
Well, it does exactly the same thing as it does in the face. So for people who have wrinkles, it's because the muscles are contracted. They're not able to relax. So you put in the Botox and it blocks the nervous transmission that makes the muscle contract. So it forces the muscle to be able to relax. And it's the same with the bladder. So you have these detrusor fibers that are causing, we need them because they squeeze our bladder to help us empty. But if they're squeezing too much, you're in this constant state of contraction. So by putting injecting Botox into the wall of the bladder, it forces the bladder muscle to relax, and the urgency and frequency dissipates.
And how do you do that? How do you go in through?
You put a camera called a cystoscope in through where a person pees from. You can do it with her awake, or you can do it asleep. And then you fill the bladder with water. So it's like being inside the room. You're seeing the inside of the bladder, like being inside a balloon.
Okay.
And then you introduce this fine needle, which comes into your view. And so the needle comes forward into your view, and then you can pick your spots, and we do 20 little injections. You spread it across the bladder. 20 little injections of 0.5 ml at each site. And the whole thing takes 3 minutes to do.
And do they need to return every 4 months or 3 months?
No, they usually get an average of about 7 months relief from their symptoms, and then the symptoms slowly start coming back.
Okay.
Now you can have someone who said it was fantastic, but after 3 or 4 months, I was feeling it was coming back again. I had actually a lady today that we did a repeat Botox, and she said that she hasn't had it done for 3 years, and that the last time I did it for her, she got at least 2 years. But with COVID and that, she got delayed. But she felt that she got 2 years relief out of it. So, but the average is sort of several months.
Yeah, could that be a certain amount of muscle memory in that if you get longer, or that's mad? Because
probably
Botox
depends on the severity of how bad they are. It's probably multifactorial.
Yeah, absolutely. So someone said that they have MS and they've had the Botox in the bladder 3 times, but they're still fully incontinent. Is there anything that can help them?
I have a few MS patients who I do Botox on for overactive bladder regularly and have had a great result with it.
Okay.
I would treat the MS patients in an identical way to the other patients with overactive bladder.
Okay.
But that may be something that they want to check with their neurologist about.
Okay.
There may be other issues there.
Yeah. And for stress incontinence, can surgery help that? Or
yes. There's everyone. It's the nice thing about surgery is everyone has slightly different ways of approaching it. Like a chef making a meal, we all have our own opinions on what is the best.
Do you ever fight amongst each other?
Yeah, we do, of course. At the meetings and that, people have very strong opinions. And
we're doing it my way.
Yes, I think this is great. And someone else said that's no use. So we have our different opinions on what works well. But in terms of surgery for stress incontinence, at the moment what I do is I would start off with a bulking agent, which is very non-invasive, very easy, very safe. It's putting a little camera into the tube that she pees from, and you inject these 4 bubbles of gel into the walls of the pipe. And it's like putting 4 speed bumps.
Is that Bulkamid?
Bulkamid is the trade name of one that we use.
Okay.
And it's a water-based gel. And I was skeptical about it at first, but I'm using it a lot now, and I'm getting fantastic results with it. I really, really like it because it's so safe, it's so easy. The problem with it is that it often does have to be repeated. I find that about at least a third of people would need a second treatment to get a good, to get where they want to be. But if it works, fantastic. And then if it doesn't work, then I would go to something more invasive. We used to use the mesh mid-urethral sling. Mm-hmm. Very, very different to what we were talking about earlier with the mesh for prolapse.
Okay.
The mesh sling was just a little sling. It's like about as wide as your finger of suture material. That suture material that we've been using since the 60s, polypropylene. So it's a little sling of suture material. It would run loosely under the tube that she pees from and just restores that support. Because of the controversy over the prolapse mesh, it has gotten a lot of bad press. And in the UK and Ireland, the mid-urethral sling, mesh sling for stress incontinence is currently suspended. But the entire rest of the world are using it as normal.
Okay.
So I think it's very likely that sling will be reintroduced in these islands, but we'll have to wait and see. But it's been suspended with the prolapse mesh since 2018.
Okay.
So we can't use it here in Ireland or Britain at the moment, but the other countries can use it. The whole rest of Europe, Scandinavia, Australia, America are using it. But we can't use it here at the moment. What we can do, and what I do then as a next step, is a natural sling. So this is where I would make an incision in your lower tummy around where a woman's panty line would be, like a very small cesarean section scar. Go under the fat there and harvest a strip of her tummy support, again about as wide and long as your finger. Take it out of that incision, close that wound, and then bring that down to the vagina and create a sling like we did with the mesh, exactly the same. And you create a sling of support underneath where she pees from. So it's all natural, there's no mesh at all involved, and it works incredibly well. But from our point of view, it's more invasive because
like
now
a magician, the way you're just explaining that.
It is
I'm a
magic.
little bit mesmerised by you saying, I took a little bit of this and I did a little bit of that.
Yeah, no, it's fabulous surgery. It really is. And it's very, very rewarding to do because people come back. It's not like you've had a lump taken off or something. Yeah. Women come back. I remember I had a lady yesterday who came back 6 weeks after having her bulking agent done for stress incontinence, and she was nearly in tears. Has changed my life. I can't believe I lived with this for so long. I'm back running. I just can't believe it. I didn't think it was possible, and like it's so rewarding to do.
That is very rewarding, and actually, and I probably should have asked you at the very start, what got you interested in this whole area, because it's very niche, really, isn't it?
Yes, it's funny. I didn't go straight into medicine. I did a science degree first, and I worked for Johnson & Johnson in the United States for a few years. And I remember being at a meeting in Johnson & Johnson, and they talked about urogynecology, and they were talking about the treatment of urinary incontinence, and that this is an enormous group of women that are out there, and nothing is being done for them. Yeah. And we're going to put a lot of resources into this area because it hasn't been touched, and there's a huge demand there. Yeah. And I remember at the time, and I wasn't doing medicine at the time, I remember thinking, that would be a very interesting area to get in on the ground floor. And that was where I remember the first time the seed was planted. And then when I ended up going back and doing medicine, it was kind of always in the back of my mind. I loved obs and gynae from the first time I went in as a medical student into the Rotunda as a student, and I just thought, wow, this is very exciting stuff. This is what I want to do. And then everyone does their obs and gynae training, and then a lot of us, at the end of your training, you sort of specialize in a subspecialty area. So whether it's infertility or gynae cancer or maternal fetal medicine, high risk pregnancies and that sort of thing, or something like urogynecology. So and urogynecology was, there wasn't many people doing it. Yeah. There was only a very small number that were doing it in Ireland at the time. But I thought that would be an interesting area to get into.
And you still deliver babies now as well, do you?
Still, I was on call last night for Holles Street. So I do that as well.
But, God, it's busy for you. So I wanted to get on to talking about the vaginoplasties and the vaginal rejuvenation and the vaginal surgeries that you can do for people, and kind of discuss that a little bit, because it has come up, and it's kind of a relatively new topic of discussion in Ireland. And I suppose there's the aesthetic area of it where women just want to look better because I suppose they're trying to adhere to some kind of typical stereotype. But then there's also the sexual dysfunction area that's involved. So would you like to talk me through a little bit about that?
Yes, I would. I mean, I think it's important. I don't like this sort of designer vagina and this sort of thing. There's a very good distinction to make between what we call reconstructive surgery and cosmetic surgery.
Yeah.
So reconstructive surgery means restoring the anatomy to the way it was, repairing and putting things back the way they used to work. And that's very much what I do. And that's what urogynecology is about. Cosmetic surgery is about changing what was normal or what was there originally, whether trying to enhance it or change it. So with vaginal surgery, as we were talking about earlier, the vagina after childbirth can be too wide and sensation with intercourse is lost. She's passing wind, queefing, I think you call it, passing wind through the vagina.
That's your new word for today.
Yeah, that's my new word that I learned. So that is a defect that has been caused by having the baby, and reconstructive surgery will put her back, not doing something cosmetic that she didn't have before, just trying to because I think that's really what most women want, is they want to be back the way they were. They're not really looking to be enhanced in any way. And then the other thing is when things are sore and things have become too tight, is she's healed too well or was stitched together a little bit too tightly, and that's causing pain and discomfort, and that can be surgically repaired quite easily. The other problem that you see is labia. So the labia can be excessively long. It's always a conundrum for me because I examine lots and lots and lots of women. There is a variability, of course, in everyone, but the numbers of women with excessively long labia, in my experience, it's not that as much as maybe we're led to believe in terms of causing symptoms.
And actually, that's what I was going to ask you. So does excessively long labia cause sexual dysfunction, or is it more that it affects their self-esteem and therefore they're worried about how their partner's looking at them?
The ones that I see, it tends to be more that it's causing a problem, a physical problem. So they'll say cycling is a problem, where things can get pushed. If the labia is too long, it gets pushed inside, or it's rubbing against something, or it gets pushed inside with intercourse.
Okay.
The conundrum I was going to say for me is that sometimes I examine someone and I think her labia are excessively long compared to the average. And then the thing is, she hasn't mentioned that to me. That's not why she's here. I don't want to give her a complex.
You're going to get asked now. What do you think, Gerry?
Yeah, well, if they ask me, I'll tell them. And I'm also, so, and at the same time, maybe it is something that she's just embarrassed to talk about.
Yeah.
So I'll try and say in a very, very matter-of-fact way, I think that your labia, have you ever noticed, do you get any problems with your labia being pushed inside or painful during exercise or intercourse? And a lot of times they'll say, no, I haven't had a problem with that. And then I'll say, in my estimation, your labia are excessively long on one side or the other side or both sides. But if it's not causing you a problem, then it's not a problem. Yeah. But a lot of people, this is becoming more of a thing where people are getting it done for aesthetic reasons, and they don't like the way it looks.
It's horrible to think. Do you know what they call it, the Barbie over in the States?
Yeah.
That's just so wrong, though, isn't it?
I had an early experience with this when I was a trainee, and a pain specialist working in one of the hospitals came to me and said, listen, I've been asked to see this lady who's up on the ward. She's got terrible pain in her vulva and vaginal area, and everything looks very normal, and she's had surgery in that area. Would you come with me and have a look? So we went together to see the patient, and this was a young married lady who had, for cosmetic reasons, had a reduction of her labia. It was actually a plastic surgeon who had flown in from the continent and was doing doing clinics here. This is 10 years ago, had flown in, paid a lot of money to have this done, and it was too short. So it was this sort of Barbie look. She now couldn't have intercourse at all. Her marriage was on the rocks as a result. This had been going on now for a couple of years. And to look at it, it looked like a Barbie doll, and it looked absolutely perfect. But the thing is, you can't put anything back once it's gone too short. And now she had this chronic pain that was going to be very difficult to manage. And I just thought, for what?
I know.
For what? So I would be I always prefer to do, I have no problem doing it for a physical problem where it's hurting her. But if everything's working well and it's comfortable for her,
yes,
do you really want to throw the dice and take that chance, that you could end up with a chronic pain problem?
Yeah, no, absolutely doesn't seem right at all.
No.
But the sexual dysfunction part of it is very important when it's affecting a woman's
totally, and I do it for
life.
those reasons.
Yeah.
If the labia are causing her a problem and I think they're excessively long, then I think she should definitely have them reduced.
Yeah,
and I do them fairly regularly.
Well, can I read a message that I got in from someone who you actually looked after?
Okay.
So she just said, because she says, I wonder who you have on. If it's Gerry Agnew, I want to send you in a nice message because he looked after me. And it was, Gerry did promise me my sex life would be better after the surgery. And he was definitely right. Although I did feel a bit like cheating when he got to examine me both ends post-surgery. It didn't help that there was a certain je ne sais quoi about him.
Okay.
So you made her feel better anyway, and I'm sure countless other women. And it's so important, I think, that this is discussed and that women know that there's things that they can do to help them, whether it be, the exercises, going on the long waiting list to see someone like yourself, but certainly it's a conversation that definitely needs to be opened up, isn't it?
Absolutely. And there is help out there. There's very few people that we can't help. So if you have these problems, whether it's a sexual dysfunction or it's prolapse or it's incontinence, don't put up with it. Go to your GP or go to a women's health physiotherapist, ask to see somebody. I think a lot of times in the past, surgeons in my specialty were guilty. I mean, urogynecology is a very new subspecialty in medical terms. It's really only about, 30 or 40 years old. And before, it was general gynecologists who were fantastic, who could do a little bit of everything. But this area was not well catered for. And I think a lot of times women went with these problems and they were told, what do you expect? You've had babies. You're fine, we'll put a ring in, or, and they were fobbed off that way. And I think the women sort of felt, that was, the male dominance and they were putting us down. Actually, it was because they really couldn't fix it.
They couldn't
They didn't know what to do and they were afraid and they knew they couldn't do it well.
Yeah.
And I think it was a way of just sort of kicking to touch, really. That's really what it was, because they didn't really know what to do.
Yeah.
But now that it has improved so much, and we really it can be sorted out. So don't let anyone tell you that it can't be.
Absolutely. And just one thing, you just touched on it there and I forgot to actually mention it, the ring pessaries that you can put in.
Yes.
Can someone use that for the rest of their lives?
Absolutely.
They can.
I have women I've been seeing since I became a consultant who come every 6 months and they have their pessary changed and away they go. And you offer them surgery and I offer them a pessary. If a woman wants a pessary, there's nothing wrong with using that for the rest of her life. It's funny because a lot of women say, I don't want one of those pessaries. I just want the surgery. And I'll say, that's no problem. We'll do the surgery, but it's going to be, a few months wait. I think I could put a pessary in for you right now and give you instant relief.
Yeah.
And often you can tell by the shape of the vagina. Some of the vaginas, it's not going to work. It's going to fall out, or it's going to be loose, or it's going to be uncomfortable. But for some women, their anatomy is perfect for a pessary. And if I put that in, it's going to give her instant support. And they'll argue with you and they'll say, I don't know. My friend told me she had one of those and not to let you put one of those in, that they fall out. And, and then you put it in and she comes back the next time and say, come here. Do I have to have the surgery? Can I not keep this?
Yeah.
And I absolutely.
Okay. And once it goes in, it stays in. They don't need to take it out to have intercourse or anything like that, do they?
No. Some of the younger women prefer, just for their own sake, they prefer to take it out.
Okay.
But they're very much in the minority.
Okay.
The vast majority of women just put it in and they just leave it there.
Okay.
When you put a pessary in, I always say, I want you not to know that it's there.
Okay.
If you know that it's there, even if it's not hurting you, but you're conscious that it's there, then the size is not right. I want, when I put it in, that you say, have you put it in? I don't know. I can't feel that it's there. Is it there?
Okay.
That's what I want.
Okay.
Because they should just forget about it. It shouldn't even know it's there. And they can have intercourse with it as normal, do everything as normal.
Okay. And it's just keeping everything in place and can potentially either stave off surgery while they're waiting for surgery.
Yeah, it can give them relief while they're waiting. So I'll say, if they still want the surgery, that's fine. This will give you relief. when you come to the surgery in a few months' time, when you're asleep, the first thing I'll do, I'll take the pessary out, throw it in the bin, and then we'll do the surgery. But there's absolutely nothing wrong with using the pessary forever, and we just change it every 6 months.
Okay. Gerry, it's been an absolute pleasure. To wrap up, though, I wanted to ask you a couple of questions that are nothing to do with urogynecology, but they might be with the answers that you give. I wanted to know what do you think the meaning of life is, and if you had any words of wisdom for our younger generation, what would you say to them?
Well, in terms of, I'm not sure that any of us are in a position to give anybody advice, but a good piece of advice that I got from my parents when I was young and starting off on, your working career, as a teenager starting to work, and that I pass on to my own kids is never, ever, ever say the words, "That's not my job."
Oh, yeah.
That's not my job. You may be technically correct. You may be within your rights, but it gives such a bad impression of your attitude. I don't want, and it's funny, even to this day, if I hear somebody saying that, even in the distance at work, I don't want that person on my team. I don't even want them in the building.
Okay.
I just think it's such a bad attitude.
It is, actually.
And you just don't get on in life if that's your attitude to work. So that would be my one nugget of advice. In terms of the meaning of life, I don't know. I love this theory that maybe we are, I would love if it was true, that we are spiritual beings who are just having a temporary physical experience. And that this is sort of like a J1 or something that we're on. And as part of our larger experience, I think that would be nice. But I don't know. Maybe at the end of it all, someone will open up the envelope and tell us the meaning of it all. Maybe they will.
I love it. Gerry, it's been an absolute pleasure to have you.
Thanks
and
for
I hope
having me.
that everyone has enjoyed and learned so much. I've learned loads, and I know that there's women all over the country now that will be phoning up looking to see either hopefully a women's health physio anyway to start the ball rolling.
That's the first port of call.
Yeah, and let's get going with it. So thank you very much.
Thanks for having me. It's been great.
Take care. Bye.